In this video, you're going to learn the nursing process on patients with heart failure. We're going to start it with what is heart failure, then we're going to move on to the concepts, then explain a little bit about the pathophysiology, then start with the first nursing process, which is assessment, then come up with a couple of diagnoses, and finally, we're going to talk about the intervention, patient education, and lastly, the quality measures of heart failure. Now, we're going to start with what is heart failure. So heart failure is actually a clinical syndrome where it consists of reduction in cardiac output, tissue hypoperfusion, increased pulmonary pressure, and there's some sort of tissue congestion. Tissue congestion can divide it into pulmonary congestion and systemic congestion. And if you look at the bubbles that are pink in color, those are the concepts related to the subtopics. For instance, reduced cardiac output and tissue hypoperfusion is closely related to perfusion issue. And if you have increased pulmonary pressure and pulmonary congestion, then obviously there's a problem with fluid balance and even gas exchange. Now we're going to move on to the concepts. Now you have already learned about the perfusion concept, gas exchange concept, and fluid balance concept. There's another concept that to keep in mind when taking care of patients with heart failure is electrolyte balance. Focus on the pathophysiology. I'm going to go over the basic pathophysiology of heart failure first, then we're going to go over the types of heart failure. Now, for pathophysiology, I'm using this concept map from the calgaryguide.com. So as you can see on the left-hand side in blue bubbles, those are the risk factors or the etiologies that lead to the left-sided heart failure. So as you can see, there's dilated cardiomyopathy, some sort of valvular condition, myocardial infarction, severe hypertension, aortic stenosis, again another valvular condition, cardiac tamponade, and also cardiomyopathy that you're going to learn in third semester. So what are the mechanism of action? You can go over all this, but ultimately what happened with systolic dysfunction is because the left ventricle unable to squeeze or empty well. So that's why there's a decrease in ejection fraction. We call it heart failure with reduced ejection fraction. Then for diastolic dysfunction, the left ventricle cannot relax or fill adequately, so the ejection fraction is preserved. So we call that heart failure with preserved ejection fraction. Ultimately, both of these dysfunction lead to left-sided heart failure. Left-sided heart failure is going to decrease in stroke volume, decrease in cardiac output, so not enough blood is going to pump out to the systemic vessels to meet the body's metabolic need. This is one part of the equation. The second part is the blood is going to back up into the lungs, causing pulmonary congestion. So if a patient has left-sided heart failure, you're actually having a perfusion issue, and at the same time, you have a fluid volume issue and lead to gas exchange issue. Now, what about the right-sided heart failure? So the right-sided heart failure, the etiologies can come from the lungs or the heart itself. So lung diseases like COPD, interstitial lung diseases, or even the problem with the pulmonary vasculature like acute pulmonary embolism or pulmonary hypertension can eventually lead to increase in pressure in the right ventricle. So there will be increase in afterload in the right ventricle, and the right wall extends and stretched, and eventually, based on the Frank-Starling law, the right ventricle is gonna fail. On the other hand, there's a cardiac disease. So anything you think about the right-sided valvular disease, like the pulmonic valve and the tricuspid valve disease, and even the right ventricle infarction can lead to decreased contractility on the right ventricle. So that will also lead to failure of the right ventricle. So important thing to think about the right ventricle is, yes, it's going to have decrease in perfusion, so perfusion to the lungs. But also, the more importantly, you want to think about the backflow. The backflow, and that will be buildup of the fluid. So there's a fluid balance concept here. So fluid backs up to the rest of the body, and you're going to see these signs and symptoms. Now we're going to take a look at the two mechanisms that are important for the heart failure disease process. First is the compensatory mechanism, and the other one is the counter-regulatory mechanism. Now, the compensatory mechanism consists of the sympathetic nervous system, neurohormonal system, and the myocardium itself. So the sympathetic nervous system, when the patient is having heart failure, there's obviously a decrease in cardiac output. Then the heart is going to increase in heart rate to compensate for the decreased cardiac output. The heart also increases in contractility, so you think about perfusion, and also the blood vessels is going to constrict. Then that will further increase in afterload, and that might impair the perfusion. As for the neurohormonal system, they consist of the RAS system, the antidiuretic hormone, and the epi and norepi. So the RAS system is the renin-angiotensin-aldosterone system. Angiotensin 2 is a potent vasoconstrictor, so it's going to vasoconstrict and increase in afterload. So that's going to be problem with the perfusion. Aldosterone, it is another hormone that helps with retaining of sodium in water, and that's going to increase in preload. Increasing in preload is going to increase in fluid balance. That's not going to be a good thing. Antidiuretic hormone is going to retain water, and again, it's going to increase preload and affects the fluid balance. Lastly is the epi and norepi. Epi and norepinephrine are the catecholamines, so increase in release of epi and norepi is going to cause vasoconstriction, it's going to increase in afterload, and potentially is going to impair the perfusion. We're going to move on to the myocardium. So myocardium, when the patient has heart failure, is going to lead to hypertrophy or dilation. Hypertrophy initially is going to increase in cardiac output, but over time, the cardiac output is going to decrease. Then again, we're going to think about perfusion issue. Dilation, the heart is not going to pump as well because of dilated heart. So the cardiac output is going to decrease and leads to perfusion issue. Now we're going to look at the counter-regulatory mechanism, which is a good mechanisms to have for heart failure. First is the natriuretic peptides. The natriuretic peptides inhibits the RAS system, so when it inhibits the RAS system, it's going to increase in diuresis and natriuresis. Natriuresis is basically removing of sodium and water. Both diuresis and natriuresis is going to decrease in preload, and that's going to help with the fluid balance. It also helps with vasodilation if it inhibits the RAS system, so it's going to decrease in afterload and helps with perfusion. Examples of natriuretic peptides would be the ANP and the BNP. ANP located in the atria and the BNP located in the ventricles. What about the nitric oxide? Nitric oxide is a potent vasodilator, and that's going to help with decreasing afterload, and that's going to impact the perfusion. Now we're going to look at the types of heart failure. First, we're going to look at the systolic versus diastolic dysfunction. Now, for systolic heart failure, there's an inability for the heart to pump effectively, so you will expect a reduce in ejection fraction. We call it HFrEF, heart failure with reduced ejection fraction. That means there's a problem with perfusion because of decrease in ejection fraction. If the heart is not able to pump effectively, fluid is going to back up, so there's always a fluid balance issue. Then you have the diastolic heart failure, which is an inability of the heart to relax effectively. Ejection fraction is normal. We call it HFpEF, heart failure with preserved ejection fraction. Now, if your heart is not able to relax effectively, then there's a problem with filling the chamber of the heart with blood. So fluid is going to back up. and then you will have fluid volume issue. Okay, next we're going to look at the right-sided versus left-sided heart failure. Now, the left-sided heart failure, there's an impaired forward flow, so that's why you have a decrease in cardiac output. So that's why the patient will have a problem with perfusion. Left-sided heart failure also have an increased backflow, and that will increase pulmonary congestion. Increase in pulmonary congestion is going to increase preload in the right side of the heart, and that's going to impair the gas exchange and also increase fluid balance. For right-sided heart failure, there will be increase in backflow and increase in systemic congestion, and that would lead to fluid balance as well. Causes of right-sided heart failure, again, we talked about that just now, mostly caused by left-sided heart failure, and can also caused by chronic lung conditions. Now, what about the acute versus chronic? Now, acute decompensated heart failure, we think about it as unstable heart failure. As for chronic, patients are usually more stable. Acute decompensated heart failure increases pulmonary congestion, and pulmonary edema is very common. So you would think in terms of gas exchange and fluid balance. And unstable heart failure also decreases in cardiac output, and that leads to decrease in perfusion. So when it comes to acute decompensated heart failure, you want to think about ABC, because it is a life-threatening condition. For chronic heart failure, you think about fluid balance, perfusion issue, and gas exchange. Now we look at the stages and classification of heart failure. Now, for the stages of heart failure is based on the American College of Cardiology and American Heart Association, the stage A until D. It is based on the structure of the heart. As for the classes, is based on the New York Heart Association classes from class 1 to class 4. Now, there's a little bit correlation between the stages and the class, and I'll go over a little bit. Now, stage A is high risk for developing heart failure, but there's no structural disorder of the heart. Stage B, there's a structural disorder of heart, but never developed symptoms of heart failure, and that correlates with class 1 of New York Heart Association because there's no limitation of physical activity. Stage C, there's a past or current symptoms of heart failure and symptoms associated with underlying heart disease, and that correlates with class 2, 3, and 4. I'll go over class 2, 3, and 4 in a little bit. Now, stage D is the end-stage disease, requires specialized treatment strategies, and that's closely related to class 4. Now, the classes is based on how the patients are able to perform specific activities or based on the symptoms. Class 2, there's slight limitation of physical activity, but they're comfortable at rest. Class 3, there's a marked limitation of physical activity, and they're comfortable at rest. Lastly will be class 4, there will be the final class, inability to carry out any physical activity without discomfort, and symptoms present even at rest. Now we're going to go over the first step of the nursing process in caring for the patients with heart failure. Now we're going to assess a couple things. One is the risk factors, then we're going to go over focus head to toe, then laboratory or diagnostic studies, and lastly, the complications of heart failure. So let's look at the risk factors of heart failure. Obviously, age, the higher the age, the older the patient, the higher risk for developing heart failure. And there are comorbidities of heart failure. As you can see, there are a lot of them. The first one is the coronary artery disease. Now, almost 50% of all heart failure patients have coronary artery disease, and this is mainly due to atherosclerosis, which consequently going to increase in afterload, and that's going to lead to problem with perfusion. Then we have hypertension. 72% of the heart failure patients have hypertension, which is very, very common. Now, the reason why is the patient is going to experiencing constant vasoconstriction, and that's going to increase in afterload, and that will, in return, increase in oxygen demand and increase cardiac workload. Now we're going to look at the valvular disease. Valvular heart disease is very common in heart failure patients as well, about 23%. What about atrial fibrillation? 31% of the cases of heart failure have atrial fibrillation. Diabetes, that is usually due to directly related to ischemia and renal failure. And anemia, because of due to decrease in oxygen supply. And thyroid disease, specifically hyperthyroidism and hypothyroidism. Hyperthyroidism can lead to tachycardia and atrial fibrillation, and that's going to increase in oxygen demand and decrease in cardiac output. Hypothyroidism can lead to bradycardia, and that's going to lead to decreased cardiac output as well. Then we're going to move on to adherence. Non-adherence to medication is also one of the biggest risk factors of heart failure patients. What about medications? Medications that trigger heart failure. So if you can see over here, NSAIDs will be number one. NSAIDs are very commonly used because they're over the counter and they may increase fluid retention, and that will increase in preload. And think about that as increase in fluid balance. Then you have the calcium channel blocker. Calcium channel blocker is going to decrease in myocardial contraction, and that will decrease in cardiac output. So perfusion can be an issue. An exception will be the DHP, dihydropyridine calcium channel blocker, that ends with dipine. For instance, amlodipine may be used at low doses, and that might not cause in decreasing myocardial contraction. Then you have the TZD. TZD is one of the oral anti-diabetic medication, and that's going to increase in fluid retention, and that will in return increase in preload. Example will be Actos and Avandia. Thyroid medication as well, levothyroxine can trigger sympathetic nervous system, and that's going to increase in heart rate and cause vasoconstriction. So then we're going to move on to the focus head-to-toe assessment. Focus head to toe, we're going to focus from the neuro, cardiovascular, respiratory, GI, GU, and then the extremities. For neuro, you want to assess for any fatigue and weakness, usually secondary to poor cardiac functioning, and alto mental status, secondary to lack of perfusion to the brain. And both clinical manifestations are usually due to problem with perfusion. Then we're going to look at cardiovascular. So cardiovascular, you want to assess patient for any chest pain because the patient might have decrease in perfusion. S3, there's an extra heart sound that could be due to increase in atrial pressure, and that is usually due to fluid balance. Patient might have hypotension because of decrease in cardiac output and stroke volume and ejection fraction, and that might lead to problem with perfusion. If a patient has hypotension, then they might lead to tachycardia due to activation of the sympathetic nervous system, and it could be possibly due to underlying dysrhythmia. So perfusion is another issue. JVD will be jugular vein distension. That is usually the sign of right-sided heart failure, and that could be because of fluid balance. Then you have the displaced PMI, secondary to enlarged heart, because of the too much volume in the body. Murmur, sometimes you can hear that, can be secondary to valvular stenosis and regurgitation, and that will be the risk factors for heart failure. And if you have a murmur or stenosis and regurgitation, it could impact the perfusion and fluid balance. Now we're going to move on to respiratory. Respiratory, you want to assess for any shortness of breath, which is dyspnea. Dyspnea can come in positional, we call it orthopnea. So you might ask patient if they've been sleeping with a couple pillows, and if that's the case, that's probably not good because they have a problem with gas exchange. Paroxysmal nocturnal dyspnea will be a shortness of breath that occur during middle of the night, and patient usually woken up because of the shortness of breath. Crackles at the bases because of fluid accumulation, so fluid balance is a problem, and there's a fluid accumulation in the pleural space or even in the alveoli, then it's going to impair the gas exchange. Wheezing, sometimes patient might have a problem with bronchoconstriction, and that might lead to impaired gas exchange. cough. Patients sometimes might have too much fluid in the pleural space or even the pulmonary, even in the alveoli, that can be due to fluid balance and lead to cough. Then you want to look for GI. So GI, you want to assess for ascites. Ascites is mainly due to too much fluid in the peritoneum. Hepatomegaly, congestion of the liver, and sometimes even to the spleen, because hepatosplenomegaly, again, is due to fluid balance. And if a patient has ascites and hepatomegaly, then it can lead to anorexia, nausea, and vomiting. So you want to assess their appetite. GU you want to assess for any nocturia. So nocturia will be waking up in the middle of the night to void. And that is mostly due to the left side of heart failure, because if you have decreasing perfusion from the left side of the heart, you're not going to be able to urinate when you are standing up or sitting up. But when you're lying flat, that's where the perfusion increases. So that is usually because of left side of heart failure. And again, nocturia will be think about the concept of fluid balance. You want to monitor strict INOs, so strict and even hourly INOs if the patient is really acute and unstable. Now, in order to measure the net INO from previous shift, you need to make sure that you use the intake to minus the output. Daily weight. Now, daily weight is the most reliable indicator for fluid gain or loss. So when you see a question in NCLEX or in exam, you want to always think about in order to determine fluid balance, that would be daily weight will be the most reliable indicator. Now, edema is not as reliable as daily weight. Now, in order to make sure that the patient measure their daily weight correctly, you want to make sure that they do it at the same time, hopefully before breakfast, on the same scale, and with the same clothing or no clothing at all. Now, the next system will be extremities. So looking for any cool extremities that will be due to decreasing perfusion, and obviously any peripheral edema, mostly a pitting edema, that will be due to fluid balance. Now we're going to look at the labs and diagnostic studies. So if you can see over here, there's actually a lot of them, and I split them up into two. The blue ones are usually pertain to heart failure, but there are other labs that we do to rule out certain conditions. Now, we're going to start from the very top. That will be the BMP. Basal metabolic panel, you assess for electrolytes, sodium and potassium. Now, calcium and magnesium are not part of the BMP, so I want to just clarify that. But basically, you want to make sure that you measure electrolyte balance, because there are medications that you provide to the patient might affect the electrolyte balance. Then you look at the patient's kidney function by assessing BUN, creatinine, and GFR. Now, CBC will be complete blood count. You want to assess especially the hemoglobin and hematocrit. So you also want to rule out anemia, because we know that anemia is one of the risk factors of heart failure. And if the patient has low HNH, it could be potentially due to hemodilution because of too much fluid, so fluid volume excess. You can also measure urinalysis to look for proteinuria and microalbuminuria. So that is usually because of renal dysfunction. Now remember, protein are very large molecules, and you should not present in the urine. And if that's the case, then it is usually because of the kidney issue. So we can think about the risk for elimination. Then you want to measure for thyroid function test, TSH, T3 and T4, to rule out any thyroid condition. LFT will be the liver function test. So what you're going to do is you want to make sure that if a patient has ascites and liver congestion, then the LFTs will be elevated. So obviously you think about fluid balance because of the congestions, but also think about the nutrition. You know, patient's appetite, they might have anorexia. Now, if a patient has an acute and unstable and developing unstable heart failure and developing severe shortness of breath, sometimes they might do an ABG, we call it arterial blood gas, to determine any hypoxemia. So you're going to learn about ABG in next semester. So that will be a gas exchange concept. Now we're going to go into the important diagnostic or lab studies that pertain specifically to heart failure. Now, BNP is B-type natriuretic peptide. So anything above 400, the shortness of breath is likely due to heart failure. So you think about fluid balance, because the fluid is going to stretch out the ventricles that release the BNP, the peptide, and then obviously it's going to impact the gas exchange. Now, if you have a BNP less than 100, that is most likely not due to heart failure. So BNP is very useful to differentiate other lung conditions. Now, BNP can also use as an indicator to determine how effective the treatment of heart failure. So if you're giving a medication to treat heart failure, then if the BNP, when upon admission, it was really, let's say, 1,000, then upon discharge, if the provider decides to do another BNP, you're going to see that the BNP might likely to be decreased. Then we're going to look at echocardiogram. Now, echocardiogram is important to determine the ejection fraction. Now, normal ejection fraction is 55 to 60%, and that is important to differentiate a systolic heart failure versus a diastolic heart failure. So ejection fraction, we think about the concept of perfusion. Now, echocardiogram also can detect any valvular changes. We talk about any stenosis or regurgitation, especially the aorta and mitral valve. And also, echocardiogram can see whether the heart is enlarged, specifically the ventricle, the left ventricle. We call left ventricle hypertrophy. Then you look at the chest x-ray. So chest x-ray can help you to determine how big is the heart. So we look at the cardiomegaly. So there's could be a problem with perfusion. And then you also look at the lungs. So chest x-ray can determine whether the patient has pleural effusion or pulmonary edema. So again, gas exchange and fluid balance. The next one will be EKG. EKG to determine any dysrhythmia or underlying dysrhythmia, specifically AFib. So again, it's a perfusion issue, any ventricular hypertrophy, and lastly, the EKG can determine, especially 12-lead EKG, to determine myocardial ischemia, injury, and infarction. They look at specifically any changes on the ST and the T waves. Lastly, you can do a more invasive procedure such as cardiac catheterization to determine the left ventricle function, but also determine any abnormal coronary blood flow that may be the risk factor for heart failure. Okay, so the last part of the assessment, we are going to look at the complications of heart failure. So what would you predict if a patient has heart failure? What would be some complication that they might experience? So the number one complication of heart failure will be respiratory complication. So if you look at this, pleural effusion is very common, so that could be because of gas exchange. Now, pleural effusion is accumulation of fluids around the pleural space, okay? And it is very different than what we call a pulmonary edema. Pulmonary edema would be something that is unstable and potentially and usually acute, and it is usually a life-threatening condition. Now, when your patient has a pulmonary edema, fluid is going to accumulate in the alveoli, and you understand that alveoli is so important, are so important for gas exchange. So what are the signs and symptoms? So initially, the patient is going to have crackles at the lung bases. They're going to have shortness at rest. They started to get confused and disoriented, especially the older adults. And then late signs and symptoms of pulmonary edema will be frothy and blood-tinged sputum, and then the skin is going to be cold and clammy and cyanotic. So gas exchange is one of the big concepts, but also think about perfusion, because this lack of gas exchange will ultimately lead to impair of perfusion. Now, the next complication would be cardiac complication. So dysrhythmia is actually very common if a patient has heart failure, especially atrial dysrhythmia. AFib is very, very common. So But if a patient is developing AFib, then there's always risk for getting clots. So clotting is a concept here. Then you might have ventricular dysrhythmia. Ventricular dysrhythmia will be a more deadly dysrhythmia, and it is usually classified as unstable. If a patient has any sort of dysrhythmia, then perfusion will obviously be involved. Sudden cardiac death is another cardiac complication, especially with patients with low ejection fraction. I've seen patients with 15% of ejection fraction, 10% of ejection fraction. They are very high risk for sudden cardiac death. So perfusion, again, is the concept. Now, other complications related to decrease in perfusion will be renal failure and anemia. Okay, moving along, we're gonna go over the diagnosis, couple diagnoses of patients who are experiencing heart failure. So we talk a lot about gas exchange. Now, impaired gas exchange is a nursing diagnosis. We call it NANDA, impaired gas exchange related to ventilation perfusion imbalance. So if a patient has problem with gas exchange, that's gonna lead to perfusion issue. And what causes gas exchange is usually due to a fluid balance, too much fluid in the lungs, pleural effusion, or pulmonary edema. Then the next diagnosis will be decrease in cardiac output related to altered contractility, preload, and afterload. Now, if you have decrease in cardiac output, obviously you have a problem with perfusion. Fatigue is another one of them. Fatigue can be related to hypoxemia, that will be related to gas exchange, and it can also be related to perfusion. Now, the last one will be risk for pulmonary edema related to altered contractility, preload, and afterload. So this will be some potential complication. So concepts here are gas exchange and fluid balance. All right, now let's talk about the intervention. So what would you do as a nurse if a patient has heart failure? Now, I'm going to split them up into two big categories. One will be acute exacerbation of heart failure, and the other one will be chronic heart failure. So chronic heart failure tend to be more stable. So in a hospital setting or in a clinical setting, you're going to see more acute exacerbation. So acute exacerbation, the treatment goals for acute heart failure obviously will be symptoms relief. This type of patient, when they come in, they are very extremely short of breath, they are very extremely anxious, and they feel like they're drowning in their own fluids. So symptoms relief is really important. So what are the symptoms that you want to relieve? It will be gas exchange, so anything of pulmonary manifestation. You want to help with perfusion. You want to help them to reduce any fluid excess in their body, and you want to help them to cope, so reduce their anxiety level. So gas exchange. So what can you do? So you can obviously, first thing you can do will be provide oxygenation. So oxygen supplement, unless there's a contraindicated. A lot of times we want to keep SpO2 or oxygen saturation above 90% if prescribed. Then obviously there are various methods of providing oxygenation, from non-invasive to more invasive. So nasal cannula, 1 to 6 liter per minute, simple mask, usually if you want to give it more than 6 liter, non-rebreather mask, and it can lead to a machine type of oxygen supplement such as CPAP, continuous positive airway pressure, or a BiPAP will be bilevel positive airway pressure. Now, if all fails, then you have to proceed to more invasive oxygen supplementation. There will be intubation or with mechanical ventilation. Once you provide or oxygen supplement to ensure that patient has sufficient oxygenation, then you can place the patient on high Fowler, so high Fowler or orthopnic position if the patient is not hypotensive. So if a patient is hypotensive, let's say systolic blood pressure is in the 80s and 90s, then high Fowler position would probably not a good idea. Then you're gonna provide medication. So morphine is actually help with relief of distress associated with shortness of breath. That's gonna help them to calm them, reduce the anxiety level, but at the same time help with their dyspnea. Move on to perfusion. Now, how do you help patient with perfusion issue? So one thing you can do is you can sit the patient up and on the edge of the bed and dangle their feet. By dangling their feet, you actually help to decrease venous return, and that will decrease preload. So that's going to help to slow down the venous return to the heart. Or you can use pharmacological treatment. So if your patient doesn't have sufficient cardiac output, then you can give a medication called IV dobutamine. Now this is an inotropic drug. This is a critical care drug, so you're going to learn there more of that in fourth semester. Inotropic drug is going to increase in contractility, increasing cardiac output, and that's going to help with perfusion. Another drug, we call it milrinone. Milrinone is a vasodilator and / inotropic drugs, and so is not only help with contractility and cardiac output, but at the same time vasodilates to decrease afterload. So it helps with perfusion as well. IV nitroglycerin drip or even IV beta blocker push can be used if a patient is severely hypertensive. The reason why you want to give that is because you want to try to decrease the afterload. So decreasing the afterload is going to, again, help with perfusion. Now, what about fluid balance? So how can you help these patients with fluid balance? So you obviously, if you administer diuretics, then you want to make sure that you monitor the fluid status. So daily weight is important, and even strict INOs. Strict sodium restriction, so the patient should be on the low sodium diet. AHA will be the American Heart Association recommendation of sodium intake will be between 1.5 to 3 liters per day, depending on how severe is the heart failure. Fluid restriction has to be prescribed, so that helps with fluid balance, but it also helps to correct any hyponatremia. Now, pharmacological wise, then you want to make sure that you can give IV loop diuretics because it's more potent diuretics than, let's say, a thiazide diuretics. Now, loop diuretics is going to help to decrease preload, and that's going to help with fluid balance. But you want to make sure you monitor for potassium level because it's going to drop the potassium and lead to hypokalemia. So think about the electrolyte. And obviously, if you give medication to excrete out volume or fluids, then you're going to need to monitor urine output, so assess for any dehydration. Now, the next medication will be IV neseritide. IV neseritide is an endogenous BNP, which is the same thing as your B-type natriuretic peptide. So that helps with natriuresis, removal of sodium and water out of the body to decrease preload, and helps with the fluid balance. But the problem is if you get rid of volume, then you're going to lead to hypotension. So you think about perfusion. So checking blood pressure is very important when you're giving this drug. Now, remember, IV neseritide is not compatible with other IV drugs, example like heparin, so you don't want to mix with other IV medications. Now, the next symptoms that you need to make sure that you take care of when the patient came in with acute decompensated heart failure will be anxiety. This type of patient, they admitted to the emergency room, has severe shortness of breath, then their anxiety level is going to going off the roof. So you can give IV morphine to calm them down. That's going to help with reduction of anxiety. But at the same time, we talk about decreased work of breathing to help with gas exchange. But also it helps with decrease in venous return, which helps with preload, and that's going to help with fluid balance. Obviously, when you give IV morphine, you want to monitor for respiratory rate and blood pressure because that's going to drop both respiratory and blood pressure. Non-pharmacological way to reduce anxiety in this patient, obviously reassurance, tell the patient that they're going to be okay. I know it's very scary to have not able to breathe, but you as healthcare providers, and you're going to help them as much as you can to calm them down. Ask them to take deep breath and use relaxation technique might be very helpful. Now, one last important note about symptomatic relief is you don't want to use any type of beta blockers in acute decompensated heart failure. This is not actually encouraged because beta blocker is going to decrease contractility and it's going to slow down the heart rate, and that's not going to provide sufficient perfusion to the heart and the rest of the body. Okay, so now we're going to go over the chronic heart failure intervention. So treatment goals for chronic heart failure will be symptoms relief, delay progression, and reduction in mortality. Now, there are two classes of medications that helps to reduce mortality and morbidity will be ACE inhibitors and ARB. The other one will be beta blocker. Remember, I told you that in acute exacerbation heart failure, you do not want to use beta blocker. But in chronic heart failure, you actually want to use beta blockers because that's going to help to reduce mortality in these patients. Now we're going to focus on the symptoms relief. First, we're going to go into gas exchange. Now, when the patient's at home and they have chronic heart failure, what you can do to promote gas exchange is to help them to cough and deep breathe. That's going to help to prevent atelectasis, which is the collapsing of the alveoli. And in returns, it's going to help to promote gas exchange. If a patient has obstructive sleep apnea, they can use a continuous positive airway pressure like a CPAP to promote gas exchange. Now for perfusion, you can use pharmacological interventions such as ACE inhibitors, ARB, beta blockers, and digoxin. And you also can use other therapy such as cardiac resynchronization therapy, like a pacemaker, or you can do a surgical management. So we're going to go over the medication first to help with perfusion. So ACE inhibitors inhibit the RAS, right? The renin-angiotensin-aldosterone system. So it inhibits the angiotensin, that's why it decreases in afterload. So decreasing afterload is going to help with perfusion. Now, ACE inhibitors or ARB is also going to help with decreasing preload. So it also helps with fluid balance and not just perfusion. Remember, ACE inhibitors or ARB helps to prevent ventricular remodeling because you don't want the ventricles to change in size and become enlarged. And that's going to help to decrease morbidity and mortality. Now, what would you monitor when you provide ACE inhibitors or ARB to the patient? Very commonly, the patient is going to experiencing what we call a first dose hypotension. So monitor their blood pressure is vital. Then you want to monitor for potassium level because it might lead to hyperkalemia. So electrolyte balance is a concept here. Another thing you want to monitor will be their renal function. So BNN, creatinine, and GFR. You want to notify healthcare provider if the GFR drops more than 25%. Now, ACE inhibitors or ARB may not be effective in African Americans or blacks because they have low in renins. Now, we're going to move on to beta blocker. Now, beta blocker helps with perfusion by decrease the sympathetic nervous system activation, and that's going to help with decrease in afterload. Again, beta blocker helps with morbidity and mortality. You're going to monitor heart rate and blood pressure because when giving beta blockers, as they can drop the heart rate and drop the blood pressure. Now, a couple of cautions that you should use when using beta blockers is diabetic patients because beta blockers can mask hypoglycemic symptoms, or if you use a non-selective beta blockers, you want to be careful in asthmatic patients because it may exacerbate asthma. Now, approved beta blockers to treat chronic heart failure, these three: carvedilol or Corec, metoprolol succinate, which is a toprol XL, and bisoprolol, it's a beta. Now, do not get confused between metoprolol succinate and metoprolol tartrate. Metoprolol succinate toprol XL is once a day dose. Metoprolol tartrate, which is a lopressor, is twice a day dose. And again, remember, beta blockers should not be used in acute decompensated heart failure. Next, we're going to move on to digoxin. Now, digoxin is an inotropic drug. Digoxin helps to increase contractility and helps to reduce heart rate. In return, it's going to increase cardiac output and increase in tissue perfusion. So, what are you going to do when you give, before you give a digoxin? You need to monitor the apical pulse, because anything less than 60, you need to hold the medication and notify healthcare provider. You also want to monitor the potassium level, because hypokalemia can potentiate digoxin toxicity. And you want to monitor the DICH level, and anything above 2 nanogram per milliliter is gonna be toxic. So monitoring the DICH level is important. So what are the signs and symptoms of DICH toxicity? First, signs and symptoms you're gonna see will be GI, anorexia, nausea, and vomiting. Then the patient is gonna have neurological symptoms. The patient might complain of blur or yellow or halo vision. Patient might be confused. Then the last part of the clinical manifestation pertain to the heart. Any type of dysrhythmia or irregular heartbeat. PVC, premature ventricular complexes, are very common. Sometimes patient is going to lead to bradycardia. Now, this toxicity is very common in patients, in renal patients. So you want to keep an eye on these signs and symptoms before you give those medication in kidney patients. Now, if a patient develops this toxicity, what you can do is you can provide an antidote, and that's going to help to bind the dish and excrete it out. Now, for non-pharmacological therapy, will be the cardiac resynchronized therapy. We call it a biventricular pacer / defibrillator. So basically, this device is gonna have electrodes that is surgically inserted into their heart, and that helps with contraction of the ventricles. And it has a defibrillator just in case a patient went into sudden cardiac death. So this type of device is only proven, is only recommended for those patients who have ejection fraction that is less than 35%. And that would classify under class 3 and class 4 heart failure. Now, another treatment modality will be surgical management. You can have the patient, you can implant a ventricular assist device on the patient, and the patient has to wear that. Usually they wear that temporary, but while waiting for heart transplant. Next, we're going to look at how can a patient with heart failure manage their symptoms in regards to fluid balance. So they can obviously take medications such as diuretics. So that's going to help with decreasing in preload. And there are two types of diuretics. One is potassium wasting diuretics, and the other one will be potassium sparing diuretics. Now, when giving diuretics, make sure you want to monitor the potassium level. It can lead to hypokalemia. Monitor daily weights to make sure that the fluid balance, and make sure that patient is not dehydrated, and also monitoring the blood pressure. All right, so we're going to go over patient education. Now, patient education is part of the nursing intervention, okay, in the nursing process. So it's very important to teach the patient, especially when they are going home and taking care of themselves at home, or teaching the caregivers and the family so that they know what to do when they go home to prevent hospital readmission. Now, the mnemonic here is MAWDS, MAWDS. Stands for medication, activity, weight, diet, and symptoms. Now, medication-wise, you want to make sure that the patient is taking the medication as prescribed. They want to avoid medications that trigger heart failure, for instance, NSAID. And also, they want to be make sure that they check their pulse if they're taking digoxin, and their blood pressure and pulse if they're taking any beta blockers. Now, for activities, you want to make sure that they stay active and rest as needed. That's going to help with their perfusion. And for daily weight, you want to make sure that they take it every day, before breakfast, after bathroom, same clothes, same scale. That helps with determining their fluid status. And of course, you want to make sure that they're on a diet that is low sodium, preferably. However, the low sodium diet are very recommendations for low sodium diet are very inconsistent throughout different organizations. So that is up to the prescriber or the provider to determine how much sodium the patient can take. But also, if a patient is prescribed to restrict their fluid, then you need to make sure that you teach them how to do that. Now, lastly will be the symptoms. This is extremely important because when the patient starts to have worsening symptoms, they need to make sure that they report to healthcare provider, because if they don't do that, they're going to end up coming back to the hospital. So any worsening symptoms will be rapid weight gain, usually weight gain in 2 to 3 pounds in a day or 5 pounds in a week, increase in any swelling of the legs. Sometimes they might complain of like tightness in their shoes, any dyspnea, orthopnea, and paroxysmal dyspnea. They need to make sure that they talk to their provider, and coughing up any pink and frothy sputum. That will be an indication that the patient might potentially have pulmonary edema. So you need to educate your patients who are going home with heart failure that they need to watch out for all these signs and symptoms. Alright, so the last part of this lecture, we're going to focus on just the core measure. I'm going to take a couple minutes to mention about these core measures, quality measures. The Joint Commission states that heart failure is no longer one of the core measures like AMI, pneumonia, and so forth. And the Center of Medicare and Medicaid states that heart failure remains the highest readmission in acute setting. Now that's a problem because that's gonna affect our financial resources in our nation. So hospitals these days, they are very careful in terms of readmission because they are gonna get penalized, which means that they're not gonna get paid by CMS if there is any readmission with heart failure as a principal diagnosis within 30 days after the patient has been discharged. So that is a good thing and a bad thing for the hospital, because hospital might be losing money if the patient with heart failure keeps on readmitted back to the facility. But the good thing is it helps all the hospitals to make sure that they do the right thing for the patients, making sure that they get a proper treatment when they are in the hospital, and they are getting the correct information before they discharge to the hospital so that they don't end up coming back to the hospital.